talk about the calcium channel blockers in hypertension, the mechanism of action, types of calcium channel blockers, indications, precautions, contraindications and side effects. So these drugs block the voltage dependent L-type calcium channels, inhibiting the calcium current and decreasing the cellular response. Type calcium channels are expressed in the blood vessels and in the heart. In the heart, calcium is necessary for cardiac contraction, for the pacemaker activity and for conduction through the AV node. So how do the calcium channel blockers act as antihypertensive agents? So to understand the mechanism of action, it is important to know that the calcium channels are available in three states: the resting state, the open state and the inactivated state. The resting state of the calcium channel responds or is influenced by depolarizing signals. So depolarizing external stimuli stimulates the resting state and the calcium channel gets activated. The opening of the calcium channel allows the influx of calcium ions and this causes generation of action potential and a cellular response is produced. As the action potential passes, the channel gets converted to an inactivated state or the closed state, and in a time-dependent manner it reverts to the resting state and is once again available for activation by the depolarizing signal. The drugs that act as calcium channel blockers reduce the frequency of opening of the calcium channels and also stabilizes the calcium channel in the inactivated state. So the more time is taken to revert to the resting state. So the opening of the channel is reduced and also the channel remains in the inactive state for a longer time, and this reduces the transmembrane calcium current, decreasing the calcium concentration and decreasing the cellular response. So let's see what is the effect of reduced calcium current in the smooth muscles, that is the blood vessels, and in the heart. Now in the blood vessels, the calcium is necessary for maintaining the tone of the vascular smooth muscle. So by decreasing the inward calcium current, there is decreased peripheral vascular resistance and this helps in lowering the blood pressure. Also, because of reduced peripheral vascular resistance, the workload and the oxygen demand on the heart decreases and this improves the left ventricular function. Also, there is dilatation of the coronary arteries and this improves the blood flow to the heart, the oxygen supply to the heart, and this attributes to its usefulness in hypertension and angina. In the heart, the reduced calcium current decreases the calcium concentration in the cardiac myocytes and this decreases the contractility of the heart. Reduced calcium current in the SA node decreases the pacemaker activity, reduces the firing rate at the SA node. And also in the AV node, the reduced calcium current decreases the conduction through the AV node. So in the heart, it produces certain undesirable effects because of the cardiodepressant property of. So what about the effects of calcium channel blockers in the skeletal muscle? It is to be noted that the calcium in the skeletal muscle is intracellularly located and is not dependent on extracellular calcium. Thus, the calcium channel blockers are ineffective on skeletal muscles. They produce profound action on the blood vessels and heart, and the desired action is on the blood vessels to act as an antihypertensive agent. The calcium channel blockers are of two types, the dihydropyridine group and the non-dihydropyridine group. The dihydropyridine group, which includes nifedipine, amlodipine, felodipine, nicardipine, nimodipine, clevidipine. Now these drugs are vasoselective, that is, they have selective action on the blood vessels, particularly the arteries, with minimal action on the veins. So by dilating the peripheral arteries, they decrease the peripheral vascular resistance, cause vasodilatation and a fall in blood pressure. Also, they dilate the coronary arteries, improving the blood flow and increasing the oxygen supply to the heart. They have minimal action on the heart, so the cardiodepressant activity is less with dihydropyridine group of calcium channel blockers. The non-dihydropyridine group, on the other hand, which includes verapamil and diltiazem, has predominant and pronounced action on the heart. They have cardiodepressant property to reduce the cardiac contractility, reduce the firing rate at the SA node, reduce the conduction through the AV node, and through these effects, we can increase the risk of bradycardia and conduction defects and is unsuitable in unstable angina and heart failure. So, for the management of hypertension, the dihydropyridine group of drugs are preferred drugs, are the first choice drugs in the management of hypertension. So now that we know that the dihydropyridine group of calcium channel blockers are preferred in the management of hypertension, so what are the drugs that are available and the characteristic features of each of these drugs? So these drugs are nifedipine, amlodipine, felodipine, nicardipine, nimodipine and clevidipine. Nifedipine is the prototype drug, and the immediate release preparations of nifedipine produce a rapid onset of action and cause a sudden fall in blood pressure. Because of the sudden fall in blood pressure, there is reflex activation of sympathetic system causing tachycardia as an undesirable effect, because tachycardia can increase the workload on the heart, increase the oxygen demand, and this is unsuitable for left ventricular dysfunction or unstable angina. This can aggravate or worsen angina and is unsuitable in ischemic heart disease. So sustained release preparations or extended release preparations of nifedipine is useful in the management of hypertension. Amlodipine, on the other hand, overcomes the drawback of nifedipine. So it has slow absorption profile, consistent bioavailability. The plasma level of the drug is steady. There are no fluctuations in the plasma level of the drug, and they produce a slower action, and the action is long lasting, about 35 to 50 hours. So amlodipine does not show tachycardia, which is a side effect of nifedipine, and is widely used in the management of hypertension. The next drug is nicardipine. Nicardipine has anti-anginal properties. They have more selective action on the coronary blood vessels, prevent spasm in the diseased atherosclerotic coronary arteries. They are very useful drugs in the management of variant angina, and they have selective action on the coronary blood vessels, dilate the coronary blood vessels and improve the blood flow to the heart and improve the oxygen supply to the heart. Therefore, nicardipine is a approved drug for the treatment of both angina and hypertension. The next drug is nimodipine. A unique feature of nimodipine is that it has high lipid solubility. Because it is highly lipid soluble, it readily crosses the blood-brain barrier and has selective action on the cerebral blood vessels. By dilating the cerebral blood vessels, they increase the blood flow to the brain and treats neurological deficits that are associated with cerebral vasospasm after cerebral hemorrhage. So, thus nimodipine is the preferred drug in the management of cerebral vasospasm associated with subarachnoid hemorrhage. The next drug is clevidipine. A characteristic feature of clevidipine is that it has a very short plasma T-half of just 2 minutes. This is because it is rapidly metabolized by the plasma esterases. So it has a rapid onset and offset of action, and it is available for IV administration. It is useful in the management of severe hypertension and perioperative hypertension when the oral therapy is not useful. Moving on to the non-dihydropyridine group of calcium channel blockers, these drugs are preferred for the treatment of supraventricular arrhythmias and have limited use in the management of hypertension. Lastly, moving on to the side effects of calcium channel blockers. Headache is a common side effect. This is because of dilatation of cerebral blood vessels. Dilatation of cutaneous blood vessels causes flushing as a side effect. Edema is a characteristic feature of calcium channel blockers, and this occurs because of increased hydrostatic pressure resulting from pre-capillary dilatation and post-capillary constriction. So post-capillary constriction increases the hydrostatic pressure, and this causes fluid to exudate into the interstitial tissue resulting in edema. Constipation is a common side effect of verapamil. Gingival hyperplasia is a side effect of prolonged use of nifedipine. Gastroesophageal reflux can occur as a side effect of calcium channel blocker, and this is because of decreased tone of the lower esophageal sphincter muscle. The tone of the lower esophageal sphincter muscle decreases, and this causes increased incidence of gastroesophageal reflux. We have discussed the mechanism of action of calcium channel blockers, the characteristic features, the uses and the side effects of these drugs.